Welcome to State of Reform's virtual series, 5 Slides We're Discussing, with some of healthcare's most thoughtful leaders. And now, the host of State of Reform, DJ Wilson.
Welcome to another conversation here at State of Reform, part of our 5 Slides We're Discussing series. We're really honored to have you, particularly as we find ourselves making our way through this virtual COVID space. We're learning a thing or two about how to host these conversations. Hopefully you're learning a thing or two about how to make your way through this space where we're all a little bit socially distanced, but the issues in healthcare and health reform nevertheless stick with us. My name is DJ Wilson, one of the hosts of State of Reform, and I'm really honored and excited to have this panel with us today to talk about mental health access and the experience here in COVID in California. Before I jump into our introductions, I want to first orient you to some of the ground rules about how we will conduct our conversation today. For example, you're experiencing this here by video, of course, and there's a little bit of a lag between what I'm saying and what you're seeing as we produce the event, add title, slides, logos, and the like. But on the right of this screen is our chat box where you're welcome to post items under the Q&A section. And we will take those as you upvote them, meaning as you see questions that you would like posed, simply upvote it and those will rise to the top. I'll try to do my best to infuse those into our conversation so that your voice is as integrated and this is as interactive as possible. So without further ado, I want to jump right into our conversation today and introduce our panelists and then let them have a minute to explain something about the work that they're doing. First, we have Michelle Doty Cabrera, Executive Director of, it's a long acronym, but the County Behavioral Health Departments Association, CBHDA. Alex Briscoe, Principal of the California Children's Trust, and David Bond, the Director of Behavioral Health at Blue Shield Promise Health Plan. Thanks for the three of you each for joining us and for weathering this COVID storm with us. Alex, give me a rundown quickly just about what you do at the Trust and the work that you're engaged in.
Hi, everybody. At the Children's Trust, we're focused on helping the state reinvent how it supports the social and emotional health of children. Our primary focus is on Medicaid financing, but we're also looking at a number of other child-serving mechanisms that contribute to the social and emotional welfare of children.
Yeah, thank you, Alex. And Michelle, how about you? Tell us about the work of the association and the directors rather than the departments.
Thank you. Yes. I work for the association that represents the behavioral health directors for California's 58 counties. They serve both Medi-Cal uninsured as well as private commercially insured individuals who have serious mental illness, serious emotional disturbance among children, as well as substance use disorder needs, and really serve as the public safety net for behavioral health from prevention all the way through to crisis in California. Happy to be here today.
Yeah, great. And David, tell us a little bit about the work you're doing.
Hey everyone, I'm David Bond. I'm the Director for Behavioral Health at Blue Shield of California Promise Health Plan. Our mission is to ensure that all Californians have easy access to high quality healthcare at an affordable price. And at Promise Health Plan, I'm largely responsible for Medi-Cal and Medicare populations.
Yeah, very good. Thank you guys all for joining us. The Medi-Cal space is a complicated one and behavioral health is in many ways even more complicated. We're going to jump into our first slide, and the purpose of these slides is to both orient our conversation around specific data, graphics, and elements using multimedia in a way that we don't always get a chance to do in the in-person world. But it's also an opportunity to structure our conversation. So we'll spend about 8 minutes on each of these slides, making sure that folks can engage and interact with them both on the panel and amongst our audience. This first slide is a slide that we've brought to the conversation. And what you'll see is these are the results of a survey from the Centers for Disease Control, which have highlighted that self-reported incidences of anxiety and depression are now 3 times higher than they were this time last year. Perhaps no surprise, but that's a pretty steep incline. California, as a percentage of reported cases amongst population now ranks 7th among the states in the United States. Alex, let me ask you to start. What do you make of this slide? Does it reflect the kind of thing that you are seeing in your work? And what are your general responses when you see these numbers?
Well, I think it reflects a difficult truth that behavioral health is the leading cause of disease burden in our nation. It by far costs our society the most in real dollars and lost productivity of any other disease burden, but we do not spend anywhere near the amount of money or time and attention to address it. It also shows us from the children's perspective that what was already a significant problem has just gotten a lot worse. Before the pandemic, before COVID, the number of children who went to the emergency department for self-injury had doubled in the decade before COVID. There had been a 104% increase in self-injury presentations at pediatric emergency departments. And while the length of stay across all disease burdens has declined since 2014, it's actually increased by 50% for pediatric mental health. So the key reflection I have on this slide, DJ, is that we already had a legitimate youth mental health crisis. And now we have whatever happens when you not only not address a crisis, but you pour gasoline on a fire.
Yeah. David, how about from where you sit? Are you seeing these numbers spike across the board like this, particularly related to anxiety and depression?
No, absolutely. I think what's fascinating to see is that, and I'll talk a bit later in the slide where I talk about telehealth utilization, is that the 5 most frequently seen diagnoses has shifted since the onset of shelter-in-place conditions, where we're actually seeing much more like major depressive disorder, PTSD, and then several anxiety disorders have replaced other top reasons why people have sought telehealth, at least. It's fascinating what you were talking about, Alex, with emergency room utilization. Talk about this a bit more as well. Well, actually, you know what? I'll hold the ER piece for if you want to get later into my slide. I don't want to give too much of a teaser.
Sure. Michelle, how about you? I mean, it's not a surprise that these numbers are going up, given the economic and public health situation. But to Alex's point earlier, we were not really well managing mental health before this crisis. How are county behavioral health directors and departments trying to figure out how to manage through this? And specifically, there's this metaphor of the beacon versus noise, that there's a lot of noise around us, but knowing what to focus on is super important. So how are these counties trying to make their way through this time, and what are they focusing on?
Well, obviously, the safety net is there for all Californians, not just individuals who have Medi-Cal or are uninsured. And so counties already operate emergency crisis lines. We're working in partnership with our emergency response teams at the local level, as well as local public health. And in many cases, counties have lifted up specific warm lines to, make sure that the community knows that crisis counseling is available to them. We're partnering with the state in asking for a federal FEMA grant to expand the reach of those crisis counseling services into the community. I think one thing to note here is that we are obviously experiencing a crisis that is quite unique in terms of its impact on mental health in particular, but substance use disorders as well. The isolation that individuals are feeling, the inability to connect with their usual support systems or connect with them in the usual ways. Counties have been extremely agile and innovative in adapting systems in order to both reach folks where they're at and be able to use electronic means to reach individuals, but also maintaining field-based and in-person where we can. We are tracking the data, and the crisis is quite dynamic in terms of how it's playing out with various populations. And also our continuous learning about which modalities work best, whether they're sustainable, and what we're going to need in the long run. Final word on this, we do crisis response, whether it's a wildfire in California, an earthquake, or an active shooter situation. And one of the things that the county behavioral health directors have told me is that oftentimes we are among the first crew to come in and provide support, not just to the affected communities, but also to the frontline workers and responders. And we're often the last to leave, sometimes continuing those services a year or more out. The scale and the magnitude of this crisis cannot be underestimated in terms of what we'll be needing to see to support resilience and recovery coming out of this over the long run.
So that's a good segue, Michelle, to your slide here that I'll let you explain, but it certainly leads me to the question of whether we are ready and prepared and whether we are adequately resourced to both have our behavioral health system be first in and last out. Why don't you walk us through this slide that you've brought to the conversation?
Great. And, this is really informed by an experience that I had early in my policy career working for a former budget chair. She was fond of saying that we in California fund our priorities. I think, when people talk about the complexity of our behavioral health system, part of that is baked into the multitude of sort of responsibilities and mandates that the public behavioral health safety net holds. So when you're looking at this graph, for example, the teal-colored smallest bar represents the funding that we receive that is outside of Medi-Cal.
Michelle, I have to interrupt. You're kind of chopping up on us there. Why don't we, that's okay. Why don't you go back and explain again one more time the graphs and what you see there? They're pretty self-explanatory, but I want to make sure our audience gets to hear it.
Great. And hopefully the Zoom gods will be with us today. So the smallest bar represents those services, the funding streams that we get that are not applied to Medi-Cal beneficiaries. The next smallest represents what county behavioral health spends and gets in terms of our Medi-Cal population. And these figures are all in the billions. So prior to the pandemic, we were receiving approximately $9 billion total, again, to serve Medi-Cal, uninsured, as well as privately insured individuals. Post-pandemic, while spending in Medi-Cal overall went up in this year's budget negotiation, we, despite our very hard-fought and welcome augmentation from the state, which we were really grateful for, still are going to see losses heading into next year. So as the pandemic ramps up and those figures that you saw, the spikes around depression and anxiety go up, we are actually under investing in our public behavioral health safety net. There are a lot of reasons for that, but I think it's important because county behavioral health is responsible for meeting those community needs to the extent that funds are available outside of Medi-Cal. Medi-Cal and EPSDT services are an entitlement, so there's really no wiggle room around that. And we look to maximize funding wherever we can, whenever we can within Medi-Cal, but the costs of our underinvestment are not represented wholly in this chart. They show up with an overrepresentation of people with serious mental illness who are incarcerated in our jails and prisons. They show up outside of Medi-Cal in involuntary treatment, institutionalization, and they show up with individuals with serious mental illness or substance use disorders who are homeless. And so, we would urge that we definitely need to fund our priorities and invest far more in lifting up the capacity of our public safety net to meet these needs, that it's more important now than ever.
Yeah. Let me ask you, David, when you see funding challenges like this and some of Michelle's comments about the challenges there, how much harder does it make your job at the Medi-Cal plan level, or maybe throughout Blue Shield? How much harder does it make your job on the behavioral health side when counties are simply underfunded for, in many cases, underfunded for mental health services?
Sure. So, and I appreciate the question. Just for audience members who might not be completely familiar with the crossover, Medi-Cal managed care in California is responsible for the mild to moderate mental health benefits for Medi-Cal beneficiaries. Once someone has a need for an inpatient admission or has a substance use disorder treatment needs, that responsibility then shifts into the county mental health plan. The complication is we know we're working with folks who need these additional services. The county might not have the adequate funding or setup to be able to take them immediately, as Michelle was saying. So some of that coordination of care can become quite complicated when someone might need like a higher level of care to make sure that we're able to get them in immediately and maintain that coordination of care for those members.
Michelle, did you want to jump in on this question?
Sure. I think it's important to note that our mild to moderate benefit is one of the great wins of the Affordable Care Act, and it's a relatively new benefit. The County Behavioral Health Safety Net provides services to individuals who meet a certain threshold of medical necessity. So their activities of daily living and other abilities are impacted by the severity of their mental illness on the adult side. For children, counties have the responsibility to serve all children's behavioral health needs regardless of severity. And for adults, this means that we're really dealing with adult needs far beyond inpatient. There are a lot of outpatient field-based services that we have available within the county behavioral health system and within Medi-Cal that don't exist under Medi-Cal managed care. And I think most importantly and uniquely, it's really the psychosocial model of care that is so important to long-term recovery, which is not only possible, but it's our aim in the safety net to make sure that individuals with serious mental illness and substance use disorder needs can lead healthy, productive lives in the community.
And David, how at the plan level where you're thinking about a range of counties, really, I don't believe promises in every county in the state of California, right. But how does this benefit vary from one county to another, if at all?
No, and it does. And so I'm maybe a point for clarification too. For foster care youth, absolutely right. Managed care doesn't have the responsibility that goes into the fee-for-service system and through the counties. For like children who have autism, for example, the ABA benefit is all run through managed care, as well as some outpatient therapy. I think though for the adults, I think, Michelle, you really hit the nail on the head in terms of that continuity of care thing that is a bit of it's a bit of a tango between the managed care plans and the counties, as it's been sort of a new sort of separation of how the benefit is administered.
So Alex, this brings us to your slide that you brought to this conversation. One of the things I hear David and Michelle saying is that this mental health benefit is very complicated. It varies across lines of business and it varies across geography. You focus on kids in particular at the Trust. Tell us about the slide you have brought and how incidentally it really fits well with the conversation Michelle and David are having.
Yeah, thank you. And I would ask everyone who's watching to take a big, deep breath, because we're going to try to distill Medicaid for you in 2 minutes or less, specific to children. And it is a great segue from the previous conversation. I'm reminded from DJ's lead-in comments that a mentor once said to me, we have the most complicated descriptions for the things we understand the least. And there is no more winding road than Medicaid dollars into the lives and experience of low-income people. It is extremely complicated. So I have worked in health systems, from ambulances to hospitals to managed care plans to everywhere. And I can tell you that I've built all 7 of the things I'm about to tell you about. But to understand Medicaid, you actually have to follow the federal dollar. So in the upper left-hand corner of this slide, that blue dollar flows through the state to get to children and families. But to understand Medicaid, you have to disentangle your belief that it's one thing. It is not one thing. In the lives of children and families in California, it is 7 things. So working from left to right, the first and largest payer for children's health services are the health plans. And as David explained, they are increasingly an actor in the lives of kids. There are about 115,000 unique children who are served through the managed care plans, mild and moderate benefit. There's about 250,000 served through the mental health plans, through something called the carve-out. And the interaction between these two systems is not clear and is a major deficiency of our approach to supporting the challenge, the health and welfare of children. The federal law pretty much, it clarifies exactly what Michelle said, that there is no acuity differential in the social and emotional support of children. But the practice in California is to divide the responsibility up between the managed care plans and the mental health plans. And that relationship has not been clean and needs to grow. To be fair, it's new. Since 2014, I think, David, is when it was created, approximately. But the 2 major players in the lives of children and youth are their managed care plans and their mental health plan. There's also their public health department, their LGA, their school districts, their community health centers, their public hospitals, and their regional centers. And I won't go through the details of how each one of these systems claims, but as I said to DJ right before we jumped on the call, having managed Medicaid resources across most public systems, by far the most complicated and difficult and administratively burdensome transaction in the Medicaid universe is the behavioral health cost report. It is ridiculously complex, and the administrative burden is so high that it strips resources administratively from county mental health plans, and at the front line level, 40 to 50% of the time of clinicians is spent doing paperwork. So I'll stop there, David, because DJ, excuse me, I know that we want to have some conversation, and I hope this isn't too complex.
Well, you've sort of put it together very simply, graphically. It's it's one of the benefits that we hope for out of this. David, let me ask you to respond. I mean, and before responding, let me preface by sharing something that Christina Gawley once shared with me. One of the LA County, she's the director of healthcare services at LA County. She said, "We're experiencing in California healthcare a death by carve-out. We have a lot of different lines of business to meet different advocacy and community interests, and it's very hard to pull them together into a coherent framework." What does that ring true when you see this slide from Alex? What is your experience in trying to braid these threads to serve the needs of children?
I couldn't agree more. It's funny that you put the question that way. So Michelle and I are actually on a separate task force, specifically working on a model of care for foster care children statewide through DHCS. And in that call last Friday, there was a comment made. It was actually like, everybody wants to do a really good job, and everyone really has a huge focus in wanting to support and work alongside these youth. But carve-outs it's quite complicated. The system of care that's there now makes it difficult for folks to just have a seamless stream of help, really, that is easy to access and easy to understand. And Alex, I really appreciate your comment about the paperwork too. I've been that therapist for about 12 years as a pediatric trauma specialist in my practice in community settings and private practice, and I'd be surprised if it's only 40% of the time doing paperwork. And I think when you bring foster care youth into the mix, especially, the administrative burden upon the providers goes up even more.
Michelle, how about maybe offer your hope for some of the reform efforts that have been mentioned already during our conversation, like CalAIM. Sometimes that's the CalAIM process is 2 steps forward, 2 steps back sometimes. But what is your hope for where some of these conversations will go, specifically related to braiding together and making these lines of business, these funding streams, more administratively efficient? What is your vision or your observation on that question?
Well, the county behavioral health directors brought forward, a priority around payment reform for precisely the documentation burden reasons that are being cited here. And I just want to note that in this chart, for example, and with county behavioral health, what the CPE refers to is the means by which we are drawing down the federal matching funds through Medi-Cal. What it means is certified public expenditure that the public sector must put up the expense first, and then it gets reimbursed from the federal government. I would note that in this chart, only the county behavioral health departments and the public hospitals with their intergovernmental transfers are putting up their own non-federal share. All of the other elements here are funded through the state general fund. So just going back to kind of that earlier slide. And I think, our goal is, if we can move away from the certified public expenditure as the mechanism with which we pay for our Medi-Cal services, we can actually significantly simplify our billing and claiming and align more with where the rest of health care is at in terms of that, and really extract greater efficiency from our clinicians. I know it's a frustration for everyone across the board, but it's a function of federal law, unfortunately. So we're going to have to do payment reform regardless. In terms of the question about sort of the complexity, again, I think it's really important with behavioral health services to understand that, and this chart illustrates it beautifully, serving the behavioral health needs of vulnerable populations requires us to really think outside of the medical box. County behavioral health directors are extremely interested in serving children in schools because we know that they spend so little time in primary care after the age of 4 or 5. And so we want to be closely linked with child serving systems, whether it's schools, child welfare, and then, as individuals progress, being able to identify our people with serious mental illness and significant needs requires really being out in the field. So often there's stigma and discrimination against people with behavioral health conditions that's baked into the various institutions, including healthcare settings. And so you see that people with behavioral health needs are underserved by those systems. So we really need to consider that some of the complexity, some of the challenges that come with serving people with significant behavioral health needs don't go away if we simply, sort of align administrative functions. It's a much bigger job, and integration and coordination needs to happen across multiple systems.
You're watching our 5 slides. We're discussing episode about mental health access and the safety net in California during this time of COVID. We're with Alex Briscoe, the Executive Director of the California Children's Trust, Michelle Doty Cabrera, the Executive Director of the California Behavioral Health Directors Association, and David Bond, the Director of Behavioral Health at Blue Shield of California Promise Health Plan. We have about 200 people registered to be with us, and we've got about 160 folks on right now. John Laidlaw asks a question that I think follows on some of your earlier comments, Michelle, about whether we expect another augmentation next fiscal year regarding realignment dollars. Do you have any insight? You want to predict what maybe this August budget revisitation might look like, and maybe what comes in the next fiscal year?
Well, it was pretty unprecedented that the legislature and the administration agreed to put funding, state general funds in to augment realigned services to counties, which is inclusive of county behavioral health as well as core human services programs, our public health departments, et cetera. And so I just want to be clear, even though for us it resulted in sort of bridging about less than a fourth of our projected losses, it was a big deal to get that $230 million earmarked for behavioral health. As we head into the August session and next year, I think a lot depends on the overall health of the economy. We have seen some positive indicators in that the tax filings are above the Department of Finance projections by about $1 billion, but we know that needs are massive across many systems. And I think part of what we're flagging here is twofold. One is the need to look at our behavioral health system as in terms of parity with what we're doing on the physical health side. And the other one is sort of going to your first chart again, DJ, which is if we really want to be serious about our recovery and helping to avoid long-term, disabling impacts of sustained anxiety, depression, and other behavioral health conditions, we're going to have to do better. And so our hope is that by highlighting some of those funding disparities and the need, that we will be set up to have a conversation about how we can continue to look at the behavioral health system holistically as we approach the state general fund conversations next year.
David, I want to move to your slide. And I know certainly one of the biggest storylines out of the COVID experience so far has been this move and catalytic move to telehealth. Walk us through your slide here and tell us what you think it means.
Thank you. And the slide's it can speak for itself. I want to give a preface with like the two couple of things that I thought about presenting that I didn't. That I want to mention something that happened earlier. I need to talk about baseline resilience. So before I came to Blue Shield of California, I was the clinical vice president for National Suicide Prevention Organization for LGBTQ youth. We ran call centers and crisis text line and crisis chat. In 2016, which was sort of toward the end of my tenure there were two major events that happened that were perceived as very significant community crises. The first was the Pulse nightclub shooting that happened in the summer of 2016. Within the 24 hours after that shooting, where 49 people in the community were killed, the number of incoming calls, texts, and chats to our crisis lines was the highest single-day volume that we had had in 20 years. Now, it's not to say that all those people suddenly became more suicidal, but the baseline resilience for the community had already been lower. So when there's a moment of crisis or trauma, the need for additional assistance really does spike. So we're talking about people who are experiencing higher degrees of vulnerability. When we talk about a Medi-Cal population, this is already, now, of course, I don't want to make huge gaping generalizations because something like 30% of California qualifies for Medi-Cal, but we're talking about a population of people who in many situations already has the vulnerability toward crisis or the level of resilience for some levels of crisis might be skewed from other populations. And so the need for constant, consistent access to high quality care is really, really high. When you look at this graph, before shelter in place before COVID and the national health emergency, the global health emergency took place, the percentage of utilization of telehealth among all people pursuing both therapy appointments and mild to moderate benefit psychiatry was really only about 4% and hovered that way for almost all of 2019. In March, people moved to working from home and a lot of offices closed and we're not able to see people in person. And so two things happened in March. One, they closed, but the second piece was the state now allowed telephone-only therapy appointments and medication management appointments. Before March, in order to engage in telehealth for behavioral health, you were required to use a smartphone or a tablet or a computer that had HIPAA compliant software in it to do some of that face-to-face contact. But in March, now that we're able to access, members are accessing their providers through telephone only, we think that's a huge contributor to enhancing the access for Medi-Cal populations. So you can see that now from April through June, we're covering almost close to 80% of mental health visits for mild to moderate benefit, again, I'm talking about, are all through telehealth. Now, the telehealth I want to note that this is claims-based information from claims that were pulled as of July 17th. So that usually when we look at data like this, we think about at least a 60 to upwards of 90-day lag in having the most accurate data because providers don't always submit their claims immediately. We know that the appointment happened when we pay for it, when we provide the funding for it. But you can also see just how high this really is. So I think we're heading toward a new normal. In a post-COVID world, where people are going to continue to want behavioral health access through telephone or through electronic access, we've actually found in conversations with providers and others that there was a perceived level of discomfort with telehealth. Providers actually had really low levels of training, low levels of comfort providing telehealth services, as they've sort of been required to because they couldn't see people in person. The level of comfort has actually really spiked. The providers are even talking about a much higher level of a different quality of interaction where the people that they're working with, they have fewer no-shows. The providers are having less burnout, and the members that they're seeing that they're providing services to have a different level of comfort engaging from their own home. There's some challenges involved with it as well, but I think in a post-COVID world, we're going to really need to have a very close examination throughout the behavioral health world at expanding our ability to meet consumers where they are, meet clients and members.
David, let me ask you a question, which is I thought of this when I read this comment from someone who posts their name as Gauthier. So I don't know if that's a first name or a last name, but Mr. or Mrs. or otherwise Gauthier says that aren't we really essentially playing a game of political determinants of health rather than social determinants of health, pinning these things on an individual? And it makes me wonder about the impact of policy and perception of policy on telehealth. And two things I want to cite and then get your thoughts about that. One is some states, some health plans like Blue Cross in Texas has already started to dial back parity for telehealth visits vis-a-vis physical health. Certainly Texas is not California. But the other one is that CMS, there is an active conversation about rescinding the allowance for audio only telehealth visits and reverting back to video only visits, which is probably puts a real strain on a number of low broadband communities. As a plan and as a director of behavioral health, how do you see telehealth sticking around if CMS changes its view or if other health plans start to erode the parity? How much of this will be with us in 6 or 12 months?
Well, two things. First, I want to talk about in social determinants of health. I think by definition, that means the social environment and the economic environment and political environment that people live in. So I agree that there are political determinants of health, but that's all absolutely related when you consider the things that are contributing to folks' health and their access to services. And I think the second piece is there is probably going to be a non-evidence-based fear that telehealth is somehow less effective. I haven't seen good research that shows that telehealth is any less effective than in-person health. Let's see, I remember back in graduate school, day one, when you go to your practice class, they're going to teach therapists about how the importance of human connectedness and two people in a room together and how intensely important that is for effective psychotherapy. But we might need to learn a more science-informed approach. And that needs to be what dictates parity And I think this, the regulators' response to what is or isn't effective access to good care.
Yeah.
And
It's
DJ
Patrick Gauthier who he chimes in here saying, sorry about that. Patrick Gauthier from AHP in Pasadena. Michelle, do you want to jump in here?
Yeah, I just wanted to say on this point about sort of the sustainability of telehealth, county behavioral health, because we're both cost-based as well as fee-for-service, we immediately had to transition a majority of our services to telehealth modalities to keep both the clients as well as our clinicians and workforce safer. And so, we have, I think, in the behavioral health space, a little bit of a leg up on physical health in that we did already use telehealth, I think, to a larger degree. Particularly important for rural communities and ensuring access where we just don't have psychiatrists, for example. And so we had a framework to build off of. And I think one of the things that David said is so important, which is we do really need to be in a continuous learning, objective stance about what works and what doesn't, because what we haven't yet experienced is the wide range of behavioral health services that we are offering via telehealth modalities across such a broad swath of populations and for such a sustained period of time. And I will tell you that our folks worked really quickly to adapt. We got trainings in place to help clinicians understand, for example, how do you modify interventions for very small children, in the 0 to 4 or 5 range to a telehealth modality, et cetera. So we have been in active learning, training, and continuous learning, but we've noticed, for example, there's some fatigue on the part of clients. And so we've had to shorten the length of time that we have certain engagements, but do more frequent engagements with folks. The digital divide is real, and it's particularly acute within low-income populations served by Medi-Cal and the safety net. And so people may not only not have access to broadband, there's also, do you have a cell phone or a laptop or an iPad or a tablet? Do you have cell phone minutes to support, clinical interventions or internet in your home? And even if you have all of those things, do you have the privacy and the conditions which would support confidential clinical intervention? And so we're actually pulling in a direction that's sort of further in the opposite direction from where you say CMS might be leaning, which is, we really would like to see more access to text-based services for certain populations. We have seen no-show rates drop for certain lines of service in certain populations, but for others, we're finding that telehealth is actually nowhere near as effective, and we're wanting to study that and understand why, so that as we come out of this, we're not making sort of blanket assumptions about the effectiveness of telehealth, and we can better understand where it works and where it doesn't.
I should note that we have our 2020 Northern California State of Reform Virtual Health Policy Conference coming up on August 18th. That'll be 60 speakers lined up with a few hundred of your closest friends who are not, of course, in a room together in Sacramento, but are gathered virtually. And you'll have about 16 or actually 20 different sessions similar to this one going on 4 at a time. So you'll have a busy day. Love to have you register to join us at stateofreform.com. I want to jump to our last slide here. Many of you know, if you've been working with us at State of Reform or following our coverage, that we have the honor of tracking healthcare and health policy in California, but also in states like Texas, I mentioned, and states like Washington. So this last slide is one that we've brought. It comes from the Washington State Department of Health, and it was an internal memo that charted what they anticipated to be the mental health status of Washingtonians as the response to the pandemic progressed. And this was drawn from other public health disasters or pandemics, but also things like earthquakes and other matters, looking at the peer-reviewed research. And I got to tell you, Alex, I'll turn to you first. When I first saw this in a document back in June, it was a little depressing to think that this is as good as it gets in terms of our collective mental health for some period of time. That document said that up to 60% of Washingtonians would experience some acute depression. Maybe it's diagnosed, maybe it's not. And that half of those folks would likely encounter, half of the folks that did encounter depression would have a substance use disorder that could arise out of it. So when you see this, Alex, what are your thoughts? Is it really this bleak? Are we in for a rough fall? What do you think?
Yeah, it's at least this bleak, maybe bleaker. Because what isn't stated here is 400 years of structural racism and the stabilization of poverty that our nation is only just beginning to come to grips with, and that our mental health system structurally ignores by requiring a diagnosis and a largely professional and largely white delivery team. So yeah, I when I look at this chart, I see, yes, our mental health system was struggling to acknowledge the fundamental impact of race and class on social and emotional welfare, that our medical model was already straining to respond, that less than 5% of children statewide were getting anything at all, regardless of whether it was good or timely, and that we were already in a state of complete and total crisis before we disconnected children from the social networks and the communities that they rely on. So yeah, I see this as an accurate, if maybe even could be worse than this.
Michelle, have you seen any sort of document like this that sort of charts our path forward in terms of our collective mental health?
Yeah, I mean, we're familiar with this. It comes out of SAMHSA, I believe, and it's tied in with, again, some of the standard SAMHSA grant opportunities to communities that face natural and other disasters. And I would agree with Alex that what we are about to experience is quite unique in terms of the breadth and the depth of it. I can say, as a parent of a young child, just, for children, speaking to Alex's, core group, the losses that young people are facing in not being able to be in school, go to school, have, community and connection, and really combined with the uncertainty of how long will this last and what will it look like, are guaranteed to result in, a collective trauma that, again, I think as a state, as a nation, as a community, we all need to take quite seriously, because we know that adverse experiences, whether they happen in childhood or later on in your life, have an overall impact on your well-being and your ability to be resilient, to recover. And life as we know it doesn't stop because we're in a pandemic. And so these really are layered traumas. I agree with Alex that our systems were significantly under-resourced, and the time is now, if not ever, to really center behavioral health needs and make sure that we're making significant added investments and doing better so that we can come out of this as well as can be expected. But I would agree that, this is standard fare for what a normal disaster would look like, and this is not in any way a normal disaster.
I want to give each of you an opportunity to tell us what gives you hope here in the last few minutes. But before I turn to that question, I want to ask you, David, if you would take this question from Alyssa Petty. She says, she asks, for Medi-Cal children who were receiving mental health treatment prior to and even after COVID, have any of the panel, or have you noticed improvements in mental health functioning? She particularly asks about the fact that kids are out of school and maybe they're not around bullies or having some of the social stressors. Are kids getting are there positives in terms of mental health in this environment? What are you seeing? Well,
I would say that there are always opportunities for some positive things to come out of it. People might be able to spend more time with families. That could be very resilient building and very positive for some. In some families, that actually could be more harmful. We're actually seeing fewer suspected child abuse reports in California, but that might not be a result of actually reduction in child abuse or neglect. There are fewer observers with those folks. So, I think that it's a complicated, I couldn't give a direct result because I haven't been speaking with those youth. I haven't been speaking with the youth that we serve to see if how they're feeling better. But I would agree that the lack of sort of normalcy and normal routines is really disruptive to most people, and even more so for children, and especially when you talk about taking away natural coping skills. I mentioned before that LGBTQ youth, and it's in many situations, school is a safe place for them. Maybe they had a sense of community there, and maybe have to go home to families that are less welcoming and supportive. And so I think having that constant together time, it's got its ups and downs.
Yeah. So David, give us your answer to this question. What do you think in this tough time, what gives you hope as you look out over the months ahead?
I think the concept that we're all in this together, I think, and that, folks really, there's so many people working really hard to build our resiliency and try to get everybody through this. There's that every day that I live about 3 blocks from a park, and there are tons of people there and taking their dogs, and like after work we go there, and it was like there wasn't such a sense of community that has had this community trauma imposed upon it, and we all have, that is sort of, I get this, and because I went through it too, and you went through it too, and everybody's going through it together. So there isn't as much of a sense of, I'm going through this by myself, as is common with many other forms of trauma.
Yeah. Michelle, how about you? What gives you hope in this time of COVID?
Well, the one thing you can say about COVID is that it reveals many structural challenges and inequities. And so I do think that it really gives us an opportunity to think outside of the box and look at real core structural reform. And, frankly, the creativity, the flexibility, the agility, the responsiveness of our frontline workers who show up every single day and put their own lives on the line, literally, it gives me hope that we can come out of this stronger and, building toward a much better system and really understanding and giving value to the need for better systems to improve behavioral health outcomes for folks.
Yeah, very good. Alex, give you the last word. What gives you hope in this time of COVID?
I'm going to do 3 quick ones. The first thing is the nexus of COVID with the beginning of a reckoning of 400 years of structural racism. And will we as a culture finally confront a legacy of marginalization and use the mental health system as part of a response at scale? The second thing is, will we and can we finally remove diagnosis as a prerequisite for care? And finally, can we tap the existing expenditures that the state is making on children as a new source of non-federal dollars to fund a multi-billion-dollar expansion of care, mostly in schools?
Awesome. Great stuff. Alex Briscoe, the Executive Director of the California Children's Trust, Michelle Doty Cabrera, Executive Director of the California Behavioral Health Directors Association, and David Bond, the Director of Behavioral Health at Blue Shield Promise Health Plan. Thank you guys for all being with us. And thank you to the folks who have watched. I will tell you, we'll send you a video of this. It'll be up on our website as well. We'll also send you a feedback tool, a short survey that really helps us understand both how we did today and what you would like us to be talking about in the future. So until then, I appreciate your participation. Hang in there and best of luck.
Thanks for joining us in this virtual conversation and for your support of our work at State of Reform.